Hello. So today we will discuss several terms that we use in oncopathology. These are the basic terms. These are the basic terms that we all know, but especially the pre-graduate students that start with the pathology. Sometimes they have a problem to properly describe those terms and to properly define them. So we won't go into the details, but we will focus solely on the proper definitions and descriptions of those terms. And today we will discuss precancerosis, metaplasia, dysplasia, tumor, neoplasia, anaplasia, and we will finish with grading and staging. So let's start with the precancerosis. What does it mean? A precancerosis is a condition that harbors an increased risk of malignancy. So it's a condition that can lead to a malignancy in the course of the time. This risk is not 100%. So not all the precancerous conditions develop a malignancy in 100% of the cases, but there is simply an increased risk of malignant transformation. And all those conditions that we will describe in a minute have one common denominator, which is accelerated cell proliferations. Usually those conditions are characterized by cycles of tissue damage and subsequent reparation, which is accompanied by accelerated cell proliferation from the immature precursors. And these proliferating cells have increased risk of mutations that can trigger a malignant transformation. What can be a precancerosis? It can be a metaplasia, which we will describe in a minute. Some metaplastic conditions can progress into malignancy in the course of the time. Not all of them, but some of them can. Chronic inflammatory conditions. Many chronic long-term inflammatory diseases harbor increased risk of malignancy. And those two groups, metaplasia and chronic inflammations, they are very often connected because metaplasia often develops in a terrain of chronic inflammation. It can be hyperplastic lesion or some benign tumors. Many benign tumors have no risk of malignant transformation, but some of them do. Some of them can progress into malignancy. Typical example is a colonic adenoma. It's a benign tumor, but it can progress to malignancy in the course of the time. Very often, the malignant transformation is preceded by epithelial dysplasia, or as a synonym, intraepithelial neoplasia. So very often we can say dysplasia in these precancerous conditions, and the dysplasia can progress into the invasive malignancy in the course of the time. This is the example of metaplastic process, intestinal metaplasia of the stomach mucosa. Metaplasia, we will describe metaplasia in a minute, but basically it means that the one tissue type is replaced by another tissue type. And here you can see it in the stomach mucosa, in gastric mucosa. Because in the terrain of chronic gastritis, usually autoimmune gastritis or gastritis caused by Helicobacter pylori infection, a part of the stomach mucosa is replaced by mucosa that resembles a small bowel. There is an intestinal mucosa. This is called intestinal metaplasia, and in the course of the time, it can progress into malignancy, into adenocarcinoma. Example of chronic inflammatory condition is a Crohn's disease. Crohn's disease is a chronic inflammation of gut. The etiology is uncertain. We still don't know exactly what is the etiology of Crohn's disease, but the Crohn's disease harbors an increased risk of adenocarcinoma or lymphoma. Endometrial hyperplasia. That's the example of a hyperplastic condition which can progress into the malignancy in the course of the time. The hyperplasia of the endometrial glands is usually triggered by hyperestrenism. So it's usually associated with an increased level of estrogen. and we used to subclassify hyperplasia of the endometrium into simplex and complex. But this subclassification was abandoned later on because there was a high inter-observer disagreement. So nowadays we talk simply about endometrial hyperplasia. And in the course of the time, a cellular atypia can develop in those hypoplastic glands, which we call atypical endometrial hyperplasia. And this atypical hyperplasia is a precancerous condition for subsequent development of invasive endometrial adenocarcinoma. And as I said, adenoma of the large bowel, it's a typical example of benign tumor, which is also a precancerosis for adenocarcinoma. So adenoma of the large bowel can progress to adenocarcinoma in the course of the time. And now let's talk about the metaplasia. What does it mean? Metaplasia means replacement of a differentiated cell type by another differentiated cell type. In other words, it simply means that the one tissue is replaced by another differentiated tissue. And very often, this is the consequence of tissue damage and subsequent reparation. Metaplasia usually develops in a terrain of chronic inflammation or generally in a terrain of chronic irritation. So it can be associated with smoking or acid reflux. And this damaged tissue, this tissue that is chronically damaged, is replaced by another tissue which is more durable to the given type of the insult. Metaplasia can be reversible, but on the other hand, the metaplasia can progress to dysplasia, and dysplasia can progress to invasive malignancy. We can subclassify metaplasia into direct and indirect. Direct metaplasia means a metaplasia without loss of the original line of the cell differentiation. Typical example, fibrous tissue, cartilage, and bone. That's a one line of differentiation, and we can see a progression between those cell lines also physiologically. Typical example, cartilages of the larynx. If you look at the larynx of the old person under the microscope, very often you can find ossification, metaplastic bone in these cartilages. Very often even with a central bone marrow cavity. Another example is a leukoplakia of the oral cavity, for example. It means that normally oral cavity is lined by non-keratinizing squamous epithelium. But in the terrain of chronic irritation, in smokers, for example, this non-keratinizing epithelium is replaced by keratinizing epithelium, which you can see in this picture. This is the squamous epithelium, and this is the thick layer of a keratin. So there is a hyperkeratosis of the oral cavity. And grossly, macroscopically, this looks like a white plaque. That's why we call it leukoplakia. And that's why this is often biopsied, because grossly you don't know if it is just a simple hyperkeratosis or whether there is dysplasia or even invasive malignancy. Indirect metaplasia means a metaplasia with loss of original line of the cell differentiation, which basically means that the one cell type or one tissue is replaced by completely different tissue. And as I mentioned at the beginning, typical example is intestinal metaplasia of the stomach mucosa. And you can see here there is a chronic gastritis, there is a lamina propria full of chronic inflammatory cells. And here you can see original foveoli of the stomach. And here you can see the intestinal gland with the goblet cells. So this is the intestinal metaplasia. And the intestinal metaplasia can develop a dysplasia in the course of the time, and then it can progress into adenocarcinoma. So now let's talk about the dysplasia. What does it mean? Dysplasia means disorganized growth. It's usually related to the epithelium. So usually we talk about the dysplasia of the epithelium, and From the practical point of the view, it refers to some cellular irregularity of the epithelium on the microscopic level that reflects a certain degree of a neoplastic transformation of the cell. So the cells are atypical, they are weird, they look atypical because malignant transformation, the neoplastic transformation, has already started, but the cells stay in situ. There is no invasive growth. The cell stays in the original place. And the irregularity is both cytological and architectural, which we will describe in a minute. Macroscopically, dysplasia is very often we don't see it macroscopically. Very often dysplasia is just a microscopical change, or it can resemble let's say a little bit elevated plaque with a distinct color, but usually it doesn't form a mass. And here you can see the example of severe dysplasia of the epidermis of the skin, which we call Bowen's disease. And you can see the both cytological and architectural atypia. The cytological atypia basically correspond to those atypia that we will describe in malignant tumors. They can be milder. We grade dysplasia according to its severity, which we will describe in a minute, and the milder grades of the dysplasia can show milder atypia compared to the invasive malignancy. But the spectrum of the changes is basically the same. And you can see the cells have variable shapes and sizes. There is increased nucleocytoplasmic index, which means that the nucleus is large compared to the size of the whole cell, which stays the same, or the cell can be even smaller because it's immature. You can see irregular nuclei, you can see dark nuclei, which we call hyperchromasia. You can see increased mitotic activity. And as I said, there is also an architectonical change, and you can see there is a loss of maturation of the cells. The cells beneath the surface look the same as the cells at the base. So there is a loss of maturation. But in contrast to invasive malignancy, the basement membrane is intact. So there is an intact basement membrane, and the cells stay in situ. But when the cells start to penetrate basement membrane, we call it invasive malignancy. It is not dysplasia anymore. And we tend to grade dysplasia according to its severity. We used to use 3-tier or 4-tier grading system as a grade 1, 2, 3 and carcinoma in situ, or in other words, mild, moderate and severe dysplasia and carcinoma in situ. But in this 3 or 4-tier grading system, there was high inter-observer disagreement. So nowadays we use 2-tier system, low grade and high grade. But please keep in mind, there is also another term, dysplasia, which has nothing to do with the malignant transformation. Sometimes we use the term dysplasia for congenital non-neoplastic disorganized growth of the tissue. So there are several congenital conditions which are characterized by congenitally disorganized growth of the tissue, and this has nothing to do with the malignancy, and we use the term dysplasia as well. Typical example is hip dysplasia, dysplasia of the hip joint, and in this condition there is a congenital malformation, congenital distortion of the hip joint, which can accelerate arthrosis in the course of the time, or cystic dysplasia of the kidney, which means there is a congenital malformation of the nephrons, which you can see microscopically as a weird looking dark tubules, and this is usually accompanied by numerous cysts in the kidney, and this has nothing to do with the malignancy. And now let's talk about the tumor. What does it mean? Tumor means swelling. Tumeo means swell. So basically a tumor is a very broad term describing a bulge. So it's a very broad general term, and it can describe something neoplastic or non-neoplastic. It can be inflammatory tumor, for example. It can be inflammatory focus that creates a bulge because there is an edema, or it can be a hamartoma. So the tumor can be both neoplastic and non-neoplastic. But please keep in mind that especially in clinical practice, a term tumor is used for the neoplasia. So especially in clinical practice, a tumor and neoplasia is used as a synonym, but the true biological definition of tumor is a bulge. So it can be neoplastic and non-neoplastic. But in the clinical practice, the tumor is usually used for neoplasia, and for the non-neoplastic tumor, they use the term pseudotumor. So now let's proceed to neoplasia. Neoplasia means new growth, and neoplasm, that's the abnormal mass, that's the result of the new growth, neoplasm. So neoplasm is an abnormal tissue, it's abnormal tissue mass with uncontrolled growth, which is too extensive in relation to surrounding non-neoplastic tissue. So it basically means that it's some tissue mass that doesn't respect the borders of the surrounding non-neoplastic tissue. And the important part of the definition of neoplasia is the autonomy. There is autonomy of the growth, which means that the neoplastic growth continues even after the cessation of the initial stimulus. But the autonomy is not 100% because each tumor requires blood supply. And if you cease the blood supply, very often you can develop necrosis in the tumor. And also many tumors grow under the stimulation, under the hormonal stimulation. And if you cease the hormonal stimulation, the tumor can regress. What is important is that the neoplasm is a monoclonal disease. It means that the neoplastic process was triggered by some genetic mutation, which was non-lethal. The mutation didn't kill the cell, but rather contrariwise, it gave the cell some advantage, and the cell started to grow. So the neoplasm is a monoclonal disease at the first. All the cells in the tumor are clones. But in the course of the time, as the neoplasm grows, the cells accumulate secondary mutation. So the advanced neoplasm is basically a spectrum of subclones with different spectra of genetic mutations. And what is the difference between cancer and carcinoma? Both of the terms refer to malignancy, but cancer means malignant tumor, generally. Cancer means just a malignant tumor. Carcinoma means malignant epithelial tumor, so there is a difference. And what is the difference between benign and malignant? Benign tumor is described as a tumor that shows bland, gross and microscopic appearance, which means it's very similar or almost undistinguishable from the non-neoplastic tissue. It stays localized and is usually accessible to surgical removal. On the other hand, malignant tumor is capable of invasive growth, destruction of surrounding tissue, and metastasizing, which means spread to the distant sites. But keep in mind, none of these characteristics is 100 specific. There is no single feature that is 100 specific for malignant or benign tumor. So it's usually basically the definition of benign and malignant is very complex, and there is many exceptions. So not a single feature is 100 specific for benign or malignant. What is anaplasia? Before we properly describe anaplasia, we need to describe differentiation, which is basically the opposite. Differentiation is a term that describes a degree to which neoplastic cells resemble their non-neoplastic counterparts. So the benign tumors are usually well differentiated, and the cells are very similar, almost the same as non-neoplastic cells. And this benign neoplastic tissue resembles non-neoplastic tissue also functionally. Typical example, benign tumors of endocrine organs, adenomas. Adenoma of pituitary gland, for example. Adenoma of pituitary gland very often produce hormones because the cells are differentiated and they are functional. On the other hand, malignant tumors show wide spectrum of differentiation. Some malignant tumors can be very well differentiated, and you can have a lot of problems to differentiate them from benign tumors. But some malignant tumors are very undifferentiated, and they are clearly malignant, and you have problem to tell the origin of the cells. And those tumors are usually afunctional. So for example, adenocarcinoma of the pituitary gland is usually afunctional, in contrast to adenoma of pituitary gland. And anaplasia is basically the opposite. Anaplasia means to form backward. So anaplasia means a loss of differentiation. As I said, some malignant tumors can be very well differentiated, some malignant tumors can be very poorly differentiated. And if the tumor is very poorly differentiated and the cells are on the level of very primitive immature cells, sometimes we call these tumors anaplastic. So anaplastic tumors are malignant tumors which are very poorly differentiated. And this dedifferentiation is cytological, architectonical, and functional. Functional, I have already described it. The anaplastic malignant tumors usually lose a capability to produce hormones, for example, or bile in a case of poorly differentiated hepatocellular carcinoma, for example. There is a loss of architecture. So, for example, well-differentiated adenocarcinoma will form glands, but a poorly differentiated adenocarcinoma will lose the capacity to grow in glands, but it will grow rather in solid fashion, or it can grow in the form of individual dissociated cells. And there are also cytological changes, which we call atypia. And usually, the more dedifferentiated the tumor is, the more atypical it is. So anaplastic tumors are usually very atypical, highly atypical. And you can clearly see that this tumor is a high-grade malignancy. And what are the features of atypia, of cellular atypia? Many of them we already described. There is a pleomorphism. Pleomorphism means variations in size and shapes of the neoplastic cells, and poorly differentiated anaplastic tumors are usually markedly pleomorphic or even bizarre. You can see it here in the left picture. You can see how atypical the cells are. Some of them are smaller, some of them are huge, with large, even bizarre looking dark nuclei. Sometimes the dedifferentiation can be towards not huge atypical cells, but towards rather small round blue cells, which you can see on the right in the right picture. So sometimes the dedifferentiation can be towards the small round blue cells, which basically look like blasts. So it's dedifferentiation towards cells that are on the level of small blasts. So the both ways are possible. Another feature of anaplasia or cellular atypia is increased nuclear cytoplasmic ratio, which means that the nucleus is bigger compared to the size of the whole cell. So the size of the cell stays the same, or the cell can be even smaller because the cell is immature, but the nucleus is large, and you can see it in these pictures. The picture on the left, this is hepatocellular carcinoma, and you can see that the nuclei are much bigger compared to the size of the whole cell, in contrast to the normal liver tissue, where you can see the big hepatocytes with smaller nuclei. Another feature is anisonucleosis. Anisonucleosis refers to the variability in the size and shape of the nuclei, which is something different from the pleomorphism, which addresses the whole cells. Anisonucleosis refers to the nuclei. And we already mentioned hyperchromasia. Hyperchromasia means that the nuclei are dark. They are usually darker than the nuclei of the non-neoplastic cells. It is caused by increased and coarsely arranged chromatin, and the nuclei are dark because of that. And sometimes we can see also changes in nucleoli. The nucleoli are more prominent, they are larger, and very often you can see multiple nucleoli in the nuclei. And the immature malignant cells usually lose a polarity. This usually refers to the epithelial cells. And you probably remember, or you probably know, that the non-neoplastic epithelial cells have some certain polarity, which means that you can tell what is the apical part of the cell and what is the basal part of the cell. You can see it here. This is the normal colonic mucosa. There are normal colonic crypts, and you can clearly see that there is a basal part of the cell with nucleus and apical part of the cell. But in case of malignant transformation, the cell loses the polarity. They are rather cuboidal or polygonal, and you have a problem to tell where is the apical part of the cell and where is the basal part of the cell. So this is loss of cellular polarity. And last but not least, increased mitotic activity. In poorly differentiated tumors, you usually see numerous mitosis, including atypical mitosis. Atypical mitosis is basically any mitosis that looks different from any physiological mitotic phase. And anaplastic malignant tumors, they are usually rich in mitosis, including atypical ones. Okay, and let's finish with grading and staging. What is grading? Grading basically tells you how ugly the tumor is in microscope. So its grading refers to microscopical assessment of the degree of tumor differentiation. We've got some general grading system that we can apply to the vast majority of the malignant tumors, which is three-tiered: grade 1, 2, and 3. Grade 1 refers to well-differentiated malignant tumors, which means that sometimes, or very often, you have a problem to tell whether this tumor is a malignancy or benign tumor. Grade 2, moderately differentiated malignant tumors. They usually look like a clearly malignant tumor, but at the same time, you can tell what is the origin of the cells. So, for example, you can clearly see that this is the hepatocellular carcinoma, not adenoma, but at the same time, you can say that this is the hepatocellular carcinoma, not some other type of the malignant tumor. And grade 3, which means poorly differentiated tumor. It means that the tumor is highly malignant and you can have problems to tell the origin of the cells, and very often you need to use immunohistochemistry. For example, you can see a poorly differentiated tumors in the liver and you need to use the immunohistochemistry to tell whether this is poorly differentiated hepatocellular carcinoma or whether this is cholangiocarcinoma or something else. And sometimes in some tumors we use a fourth grade, which refers to completely undifferentiated tumors. Typical example is undifferentiated carcinoma, which means that you can tell that this is a carcinoma but nothing else, even with immunohistochemistry. Even with immunohistochemistry, you can tell that this is the carcinoma and that's all, and you don't know is it adenocarcinoma or some other type. So this is the universal grading system, but some tumors have their own grading system, their own specialized grading system. Typical example is Gleason score, which can be used for, or which is used for prostate adenocarcinoma, or Nottingham histologic score, which is used for breast carcinoma. Here you can see the examples. On the left side, this is a well-differentiated liposarcoma. And you can see that this tumor is very well differentiated. The neoplastic adipocytes are quite mature and they look like adipocytes. And maybe you could have some problems to tell the difference between liposarcoma and lipoma. But still, you can appreciate a certain degree of variations in the cell shapes and sizes, which can help you to diagnose it as a liposarcoma and not as a lipoma. On the other hand, here you can see completely undifferentiated pleomorphic sarcoma, and here you can clearly see that this is a high-grade malignancy, but you have no chance to tell the original line of the cell differentiation. And let's finish with staging. Staging is something different from grading. Grading is basically a microscopical term. It describes the microscopical degree of differentiation. But staging, it describes the extent of the neoplastic involvement. It basically tells us how advanced is the malignant disease. And again, even in staging, we have some general staging system that can be applied to the vast majority of the malignant tumors, which is called TNM classification. T means how extensive and how big is the primary tumor. We can classify it according to the size of the tumor, according to the depth of the invasion. So for example, we can subclassify colonic adenocarcinoma, whether there is an invasion into lamina propria or submucosa or into deeper structures, or we can subclassify it based on the relation to surrounding structures. So for example, whether the kidney cancer is limited to the kidney parenchyma or whether there is invasion into surrounding adipose tissue. N means involvement of the lymph nodes. So it describes whether there are metastatic foci in regional lymph nodes or not. And M means a presence of distant metastasis. So this is the general TNM classification that can be applied to the vast majority of the malignant tumors. And TNM can be clinical or pathological. Clinical TNM, cTNM, is based on the clinical or radiological or endoscopic examinations. And PTNM, which means pathological TNM, it is done based on the histopathological assessment of the tumor. And again, similar to grading, also in staging, some tumors have their own specialized staging system. Typical example, Clark staging and Breslow staging for skin melanoma, or FIGO staging for gynecological malignancies. Okay, so that's all. Thank you for the attention and see you soon.